my name is Dr. Nerielle. I'm an academic foundation trainee based in Belfast, and today I'll be presenting our systematic review and meta-analysis on corticosteroids and postoperative outcomes in adults undergoing major non-cardiac surgery. Our aim was to determine in adults undergoing major non-cardiac surgery, do perioperative systemic corticosteroids reduce key postoperative complications? Existing reviews have focused on select populations or outcomes, however we consider the potential broad benefit of steroids across major non-cardiac surgery. Surgery stimulates the systemic inflammatory response, which, when dysregulated, can complicate postoperative recovery. Corticosteroids have evidenced benefit in severe inflammatory states, such as ARDS and severe community-acquired pneumonia, and we theorise that systemic corticosteroids may modulate the inflammatory response in surgical populations, theoretically decreasing risk of postoperative complications. Our review was conducted in accordance with PRISMA guidelines. It is Prospero registered, and the protocol with our pre-specified analysis plan is under peer review. Inclusion criteria were randomised controlled trials in adult populations undergoing major non-cardiac surgery, excluding body surface, oral or cosmetic procedures, with perioperative systemic corticosteroids administered via the intramuscular, intravenous or oral routes, and outcomes must be compared to placebo or control. Each trial had to report at least one of our pre-specified postoperative outcomes. We searched MACE and Medline databases up to the 1st of June 2026, and screening was performed in duplicate amongst 3 authors, resulting in 42 included trials. Risk of bias assessment found 2 trials at high risk of bias. However, after sensitivity analyses excluding these trials was performed, there was no change to our results. 25 trials reported our primary outcome of mortality. Our meta-analysis pill point estimate favoured corticosteroid administration, however this did not reach significance. Mortality was a secondary outcome in all included trials with low event rates. Consequently, this absence of significance should not be interpreted as evidence of no effect. Rather, that current evidence is insufficiently powered to determine effect, and this was confirmed in performing trial sequential analysis. Subgroup analyses revealed patient populations with signals of benefit, including abdominopelvic surgery, higher corticosteroid doses, and patients undergoing emergency surgery, and we found effect modification between emergent and elective procedures. These 3 patient cohorts experienced high physiological stress, and therefore mortality benefit with inflammatory modulation would be plausible. Across secondary outcomes, there was preferential attenuation of outcomes for which inflammation is an important pathogenic mechanism. We observed significant risk reduction for sepsis, delirium, and acute kidney injury. Point estimates for all other outcomes favour benefit, however none reached significance. There was no significant increase in rates of any safety outcomes, demonstrating no clear evidence of harm. In conclusion, perioperative steroids are associated with reduced risk of several key postoperative complications. However, current evidence is insufficient to determine their effect on mortality, and future research should focus on identifying patient groups who are most likely to benefit and on optimal dose and timing strategies.